Hey guys, Woodruff here. So we're going to jump into my absolute favorite section, into the real good nitty gritty. I was gonna keep doing really bad analogies, but I'm gonna stop. I think you get the point. I love cardiac. So we're gonna start out by getting into some vascular disorders. So these are my lectures, and I'm again breaking them up like I normally do. They have some interactive questions and stuff like that. But hopefully this helps you to fall in love with cardiac like I did. And I'll tell you this is that, it's not that I necessarily love every cardiac patient, but I find teaching it so much fun and so interesting. And yeah, it's definitely the highlight of the semester for me. So yeah, let's dig in. We're going to start by talking about vascular disorders in this section. This lecture is going to cover arterial disorders, venous disorders, and kind of differentiating between the two and some of the major things. So to get started, by the end, if you watch all of the lectures that are included for this PowerPoint, you're going to learn about, we're going to start with peripheral artery disease, then we're going to move into talking about arterial versus venous ulcers. Then we'll get into the big venous diseases like DVT, and we'll end by talking about varicose veins and phlebitis, more the minor things, but going to break it down into small chunks, which is easier to digest. It's always good to start with a little bit of information at a time, but to start to kind of get things a little bit more cinched in. A lot of times if you watch long lectures and things like that, I'm not saying that they're not ever helpful, but sometimes eventually your bandwidth for what you can learn runs out. So anyway, let's talk about arterial problems. So when we're talking about arterial problems, we want to think about what the arteries do or what the purpose of the arteries are. And the arteries are our blood vessels that carry blood away from the heart and specifically carry blood that is oxygenated or has oxygen carrying capacity to our tissue. So think of these like our Amazon delivery trucks that are taking from our wonderful stores of oxygen from our heart. They are taking them to our tissues and making sure they get delivered properly. So they're very important because without them, we would not get oxygen to any of our tissues. So when we have arterial problems, specifically, we're about to talk about peripheral artery disease. We're saying, okay, well, what's the delivery problem? Who's not getting delivery? And we're talking about the far peripheral tissues. It's definitely possible to have peripheral artery disease in your arms, but when we talk about it, we're usually talking about the legs. And so if I'm not getting good perfusion in the arteries that are in my legs, who loses, or like where's the lack of blood flow? And it would be my feet. So another way of looking at this is the like having ischemia like you can have in your heart, like when you have a heart attack, but in your legs. So a lot of times you can compare it to like having leg angina, and or there's a decreased flow. Effectively when you have this ischemia, it can lead to of, like I mentioned, not getting blood flow, which means not getting oxygenation. And the end result or the end problem here is that it can get so bad that I can end up losing tissues or limbs, which can obviously it's a very undesirable outcome. So let's talk about what this is and who gets it. So peripheral artery disease, you're going to see me refer it to in the future, like everything in cardiac has an acronym. So I always think of cardiac as like the cool topic. So it's got all the acronyms, like there's like their fraternity or sorority. So everything gets an acronym or a nickname. So PAD is your first acronym to learn in cardiac. At least in this lecture, there's many more. And so like I mentioned, this is a problem where we're not getting flow to our peripheral extremities, usually specifically our feet. But what's really the problem here? So what's going on here is, like I said, it's just like in the coronary arteries when we have CAD or coronary artery disease, where there's two problems usually going on. I'm usually one, filling up with plaques. And so in other words, I have a cholesterol or plaque problem. And then two, I'm also have an issue where things are getting narrow. And sometimes it's both. Sometimes I'm filling up with plaque, and I also have a narrowing of my vessels for a variety of reasons. We're going to talk about risk factors. But the end result is, think of very clogged pipes. So the example I usually give in my class is, think of, if you're someone who has hair And when you take showers over and over again, eventually the drains get clogged with your hair. Like some of it gets stuck in there, and eventually the water's not draining well. So this is a very similar thing where eventually the pipes, I'll call the arteries the pipes in our legs, they can get filled with plaque. Plaque can accumulate, and then also with time, just with wear and tear, they start getting really rigid. So even if they're not necessarily narrowing, they are getting more rigid or stiff. So they have like less flexibility, and so they end up getting very narrow, full of plaques. And so the end result is that there is decreased or less or no flow in some cases. So what would cause this? Well, people that have plaque accumulation, like hyperlipidemia, or what's known as atherosclerosis, can be more at risk for this. People that use tobacco, or are smokers, because smokers, it's two-part thing. Smoking causes constriction or narrowing of the blood vessels, but smoking also, the actual chemicals within it can break down the inner lining of the blood vessels, which can lead to plaque accumulation or more plaque-like problems. And then also diabetes, because you want to think anything that can do damage inside the blood vessel, anything that can cause the blood vessel to narrow, or anything that can cause issues with the inside of the blood vessels. And so with diabetes, remember the sugar breaks down the inner lining of the arteries, and that can lead to, again, more plaque problems. Hypertension creates very stiff, rigid arteries, and leads to excess pressure and more narrowing. We already talked about the high cholesterol. And then, of course, with increased age, everything goes downhill. It can affect one or multiple arteries. Like I said, the end result here is that there's all these plaques. I have like a narrow, like it's getting smaller of an artery, and more plaques are building up. And the end result is I have decreased, less flow to my feet, which can again lead to very serious problems. Let's talk about it. First, let's talk about, though, what it's going to look like. So if I have a blood flow problem, we have to think about what this is going to look like. So I equate this a lot to if you sit with your legs crossed for a long time, or like if you sit on your leg for a long time, eventually you get to those pins and needles and start to feel like it's falling asleep. And this is your body way of telling you like, hey, there's not good flow. And so it's very similar with PAD. If I'm getting less flow, one of the early signs, or I don't know if I want to say it's early, well, yeah, I would say it's probably earlier signs, is going to be paresthesias, or numbness and tingling. They may say that they have a shooting or burning pain, and with that numbness and tingling as well, they may say they have decreased sensation. And we always want to worry about that because, while I compared this to like your leg falling asleep, the difference is if my leg's falling asleep, I move my leg or I relieve the pressure and things are better. But the problem here is that it's a constant issue. And so, it's a very uncomfortable sensation, of course, but we have to also think about what's the big deal. If I'm having numbness and tingling, or if I'm having decreased sensation in my lower extremities, what am I at risk for? What does this remind you of? Hopefully this reminds you of diabetes, like where we have patients that end up with, the diabetic neuropathy, where they end up with being very high risk for ulcers and wounds and, problems with infection in their feet, because they're not getting blood flow. We'll talk more about the ulcers and stuff later, but just keep in mind, like anytime I have a lack of oxygen problem, I'm going to have a problem with, the possibility of dead tissue, infection, and a lot of other issues. So then the other, and I meant to mark this earlier, but I'm going to make a little note to myself so I don't forget. I'm probably not going to be able to find a pen right now, but let's see if I can find one real quick so I can make myself a note. Let's see, intermittent. All right, let me put hallmark for I see. Okay, so don't mind me. I did this lecture the other day, and I kind of try to make mental notes about what I want to update or, make more obvious. And but then I was going back through and I was looking at it, seeing if I could remember. But because it's been a few days, I couldn't remember all the changes I want to make. So what I would like to put around intermittent claudication here on this PowerPoint is it's a hallmark symptom. Like when you think PAD, like if you had to list one symptom that's the symptom, intermittent claudication is it. And what this is think of this like exertional angina, like when a person has chest pain or CAD, well, not CAD, but CSA, like where they have angina in their chest, or chronic stable angina. What happens is when they're up and exercising, they get chest pain because their body has either a decreased supply of oxygen because they're up moving around, or it has an increased demand for oxygen because they're up and moving around. So the same thing happens in the legs. What happens is that because of the lack of oxygen, your body actually switches to a completely different metabolism, and it ends up secreting a chemical that leads to this ischemic pain. But that's a really in-depth way but just think of it simply this way, is that I already have these legs that are full of plaques. Sorry, I shouldn't say these legs, these arteries in my legs that are full of plaques, and they're very narrow. What happens if I'm getting up, moving around, exercising, stressed out? They constrict even more. So if I already have a low flow problem and then I get up and I start moving around, exercise and movement is going to make that worse because that extra vasoconstriction or that extra stress. So this is how you would describe intermittent claudication is what a patient would say is that when they're up walking around, when they are when they're up and exercising, when they're stressed out, when their body is in movement, they're going to complain of having like this sharp pain in their legs. Ooh, that's something else I want to add. Thanks for reminding me. Don't mind my little notes here. So it's a sharp pain that they feel in their legs, and it usually is relieved by, it should be relieved by rest. If it's not, we got a bigger problem going on, but they should get better with the rest, because again, the reason that they are having the pain is because, when they're resting, there's not as much constriction, their blood vessels relax a little bit, but as soon as they start exercising, getting up, moving around, especially if they're exerting themselves a little bit more heavily, that constriction happens and then impedes the flow to their feet even worse. And so this leads to pain, and they usually feel it in their calf. It depends on where the blockage is, but they can feel it in their calf and their thigh, etc. It's usually seen like the typical is it's calf pain is where they feel it. Some other symptoms, as it gets worse, is they're going to have pain at rest. So just like with chest pain, for when you have like coronary artery disease and angina, what we have is that like it's getting worse if they're feeling the pain at rest. Because as time goes on, it's getting so narrow that it doesn't matter if you're exercising or not. It's so narrow, there is no room for flow. Some people can have no symptoms, and that would be someone who maybe has decreased sensation already, or like a diabetic, or it could just be someone who for whatever reason does not have symptoms. Everyone presents differently. There's also some atypical symptoms like leg burning, heaviness, pressure, soreness, tightness, or weakness. I also have up here that a lot of times as a late sign, they might have pain that's worse at night. And you have to think about that. There's two factors. And I don't know why I always want to do two. I want to do like peace signs, but let's say two factors, not four, because this is like four. Let's say two factors that really come to play here. And the first one is going to be that they are positioned in a way that they're lying flat. So because they're lying flat, they're going to have like pretty much their body has to overcome more gravity to flow, versus like if their legs are dangling, it flows a lot easier, gravity helps. And then the other thing is when you're resting at night, your heart is really starting to prioritize what it needs to spend its energy or exert itself when it comes to where does flow need to go. And so at night, your body's not sitting there and saying, hey, let me get my like toes and my fingers. It's saying, hey, it's time to rest and it's time to digest. It's busy putting those memories you have of your exciting day learning cardiac at nursing school away, and then it's trying to digest your food. And so when, that's why you have less cardiac output, because your body is more in the parasympathetic mode and it's just resting. It doesn't need as much cardiac output. It's trying to save it for when it needs it the most. And so your heart rests more, and you're going to have your heart rate can go down. There's a lot of like contributing factors, but effectively you usually have less output because you need less, or it's diverted to places aside from your fingers and toes because you're not using them when you're sleeping. Oh no, getting a little excited. Let's talk about priority assessments. Assessments. Maybe I want to add an S there. I'm going to try to get not too particular. But what do you call it? Assessments and findings that we're going to find in these patients. We're going to talk more about neurovascular when I get into my lectures over fractures and musculoskeletal, but we really do need to start here because the priority that I'm really focused on when it comes to, like, if I had one assessment that I could do on this patient, it would be a neurovascular assessment. And when I say neurovascular, I'm talking about the 7 Ps and 1 C. You may have in the past, 1, 2, 3, 4, 5. What I feel like I have 6 here. Oh, I was like 1, 2, 3, 4, 5, 6. Did I not even put all of them up here? 1, 2, 3, 4, 5, 6, 9. Apparently, I'm failing at life this week. So anyway, oh no, I do have 7. All right, I'm not crazy. It's like, wait, why am I losing my mind? I swear I can count, but yes. So, that's what I wanted to add. I promise I'm going to get back on track here in a second. Don't mind, like, most of the time I'm really on track or on focus, but today is going to be an exception. Anyway, I'm gonna stop trying to count things and look for errors and really try to focus on you. So let's get back to you. Needless to say, my priority is going to be perfusion. So a neurovascular assessment, a lot of times students get confused with that because they think neurovascular has something to do with the neuro or the neurological system or the brain. When we're talking about neurovascular, we're actually talking about your perfusion to your legs and your extremities or to your hands. So we're talking about perfusion into your, usually your extremities, things like that. And most people know either 5 Ps or 6 Ps. I have 7, and I didn't create these, but I use 7 because I also include P for pressure or edema. But yeah, I have kind of asterisked, if that's a word, put asterisks by ones that I think are the most important. And I'm acting like that's my opinion, but I put ones by the Ps that are going to probably be most crucial for you as you are doing these assessments for this particular patient. Now, for other patients, it might look a little different. Let's just get into it before I talk myself in a corner. So 7 Ps, and I'm going to count them with my fingers. There's pain, pallor, paresthesias, pulses, poikilothermia, pressure, and paralysis. So I do have 7, yay. Anyway, so let's go through them. So pain. Of course, I want to assess for pain. Now, with some patients, again, we have to remember this is an ischemic issue. They may have that ischemia pain or that sharp pain, or, as time goes on, they may have no pain, or they may stop feeling like, I want to know that they feel pain, like they should, hopefully. They might have pain like intermittent claudication, but this is not really assessing for that. This is assessing for pain in their feet. Now, you have to think, if someone was not getting blood flow in their arteries in their legs to their feet, what's their sensation going to be like? And you have to get back to that. These patients can have paresthesias. In other words, they can have decreased sensation to their feet. Therefore, they could have little or no pain. So when we're looking at this, you really should be thinking these are the 7 Ps and 1 C for the feet. So you're not necessarily assessing their calves, their thighs, because they might have pain there because there's still some flow there. The problem is there flow to their feet? So you really want to ask them or assess for pain in their feet. Can you feel this when I touch you? Does this, like, give them a little pinch? Does this hurt? Kind of assess that. Some people might have hyperesthesias or like severe pain in their feet, like kind of the opposite reaction. Anyway, so, oh, not trying to go there. I was trying to get rid of this thing. 1 second. Dun, 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 dun. Oh, no, I'm gonna leave it. Anyway, so the next one, in this one I have asterisked is pallor or color. And so this is one that's specific because we do talk about specific words when it comes to talking about PAD. When we talk about, if you look a little bit farther down on this slide, when it says what color are their legs when elevated, it really should say are their feet when elevated. See, I'm going to keep changing. Maybe this is my worst slide, and this is the one that needs the most edits. I think that there's not a lot after this. I'm going to put my fingers crossed. But I'm also a perfectionist. So just know, like, if you're thinking like, man, this lady does not have any of her life together, that's a truth. I'm a mess. But I'll tell you the truth is that I'm a perfectionist. So I would find flaws in everything in my own work. But anyway, what do you call it? When you look at these questions, there's 2 words that you want to know when it comes to the pallor or the color. And one is pallor, and pallor usually is significant. It's like a white, like they have a very like pale. Pallor usually means pale. And then there's also what's known as rubor, which is RUBOR. And yeah, I'm gonna add that too. And so, needless to say, when you're looking at an assessment on a patient who has peripheral artery disease, you have to think about what's going to help them or what's going to hurt them when it comes to perfusion. So I had a student semesters ago that taught me something that helped them. And so they always remembered A for arterial. So you make your fingers down like an A, that we want to dangle their legs. Where V for venous, we want to elevate. So we want to think about, if I have a problem, if let's say A for arterial, and I'm having a problem getting flow down my legs to my feet, what color are they going to be when I lift them up? So if I'm having problem getting flow down and then I lift my legs up or elevate my legs, what color are they going to become? Is there going to be more blood flow or less blood flow? And so with this kind of patient, because there's problem getting blood flow down, just like I talked about the decreased cardiac output and the positioning at night, if I elevate their legs, that's going to make their blood flow even worse. So they're going to become more pale or have pallor. And then if I put their legs dependent, or if I dangle their legs, and when you think of the words dependent, what it means is that their legs are dangling. You should always be thinking their legs are dangling or going down. So think of that D for dependent is down. When their legs are dependent, this is going to help their flow. Gravity is going to help to get that flow there. So when it's going to be more of that ruber, or think ruber is red. So when their legs are dangling or dependent, they're going to, or down, whatever you want to say, all the D's, they're going to have a color of ruber or red, RUBOR. Whereas when we elevate them, then I'm adding gravity, and like the body has to overcome a lot to get the blood flow to the feet. So then they're going to become more pale or have pallor. So that's one of your priority things you definitely want to look at. And then with paresthesias, we've already talked about this, that they can have the numbness and tingling, and usually paresthesias are considered an early sign of neurovascular impairment. So like, again, usually this is going to be one of the first symptoms that they have. The other really key priority assessment is going to be pulses. It's going to be one of the best, most definitive ways that I can tell if someone's having blood flow. And you can follow your pulses. So if I have someone who's poor blood flow in their legs, let's say I'm at their feet, I can't feel a pulse. I can get a Doppler, I can't find a pulse. I'm going to keep moving up until I find the closest pulse to find flow. And so I usually tell the story about a patient that I had, that I went in, and I was searching. I searched for a good 10, 15 minutes, could not find their pulses. I got the Doppler out. I listened all along everywhere I knew, and I just could not for the life of me find it. This patient ended up having DIC, and they were clotting really bad and had a lot of stuff going on. They came and did a Doppler of their extremities, and the cool thing was that, like, I'm not someone who needs to be right all the time, because I really honestly have no self-esteem. So I don't really need it. Like, I'm fine, I'm cool living in my own introverted existence. But it felt really cool because, like, I felt like I was crazy. I was like, they're gonna come here and be like, there's a pulse right here. But they came and did a Doppler, and the patient's pulses stopped before their ankles. Like, they had a really bad clot. And so, yeah, at the end of the day, the reason I couldn't find a pulse is because there's not one. So pulses are going to tell us a lot, because it tells us, like, how far down are we getting flow. If there's no pulse there's nothing that can be Dopplered, heard, felt, etc., or seen on an actual visual, like a Doppler is also a diagnostic test or an ultrasound. Then this is showing me that there is very poor flow. I also had a patient the other night who had like septic emboli or clots everywhere, and they had pretty much black fingers and toes, like every single one, but their entire arm, left arm, was necrotic or dying, and that's because their artery was blocked. And so when you checked, they had I want to say they had an ulnar. If you tried to find their ulnar, pulse, but it was completely blocked for their radial, and this is what led to a lot of their tissue death. But we always want to be checking our pulses. They're really going to give us a lot of information about how far down we're getting flow, or how far down we're not getting flow. So this is going to be another priority one. And it's a late one. Like, if I'm at the point, like if I have PAD and I'm at the point where my pulse is gone, that's a late sign. Like, patients with PAD can have decreased pulses. They could have like a 1+, but it would not be okay, or I would not expect them to have, it would not be okay, or I would need to call the doctor if they had no pulse. So, because even though it's like, hey, yeah, this is something that can happen, we need to call someone, because if you got no pulse, you got zero flow, which means you're about to have some dead tissue. There's also what's known as poikilothermia, the word that no one can pronounce, and that's okay. It really just means temperature. So what temperature would you think someone would have? So someone with someone with PAD would have, I should say. Poikilothermia is going to be all about what do you call them? Like you have to think about, when I have flow, how do things feel? If I have good blood flow, if I have blood running through my arteries, things feel warm. So for a normal patient, they would feel warm, but for a patient with PAD, there's less flow. So what do you think they're going to feel like? You said cold, you would be right, because it's going to be cool. It's going to be cool to touch. So there's also going to, on the other end, we'll talk about this when we talk about venous, there can be pressure you're going to find with peripheral artery disease. We're going to talk more about like the back and forth, what their legs and stuff can look like. But these people aren't swollen. There's no flow. Like you're going to see swollen legs in people that have too much fluid or fluid overload or fluid backflow. Like when we talk about heart failure and other stuff like that, or if there's an obstruction, like when we talk about DVT, they can have edema. But a patient in PAD has no flow, so there's not going to be any swelling. There's no flow, or I shouldn't say no flow, there's low flow. So there's not a lot of flow to cause swelling. And then paralysis is going to be a very late sign. If my foot is to the point that it has such low flow that I can't even move it, I'm in trouble. And so, that's a really late sign. So normally your early signs are going to be pain and paresthesias. So like, and this goes for like other things like compartment syndrome and stuff like that. So normally early on, what you're going to have is some, the pain sensations and paresthesias. But as time goes on, the color changes. They start to get a diminished pulses, the temperature changes, and then when it gets really late, they're going to start getting that paralysis or inability to move that leg. So the leg you really have to think about, if I'm not getting blood flow to my leg, what is it going to look like? And like I mentioned, because there's less flow, oh, look, hey, I just realized I just made a mnemonic in this moment. Hey, because there's less flow, there's nowhere for hair to grow, or what do you call it? Something like that. Yes, I like it. So because there's less flow, there's no hair to grow. Something like it sounded better in my head, but it sounds okay right now. I'll take it. But needless to say, you're going to notice their skin is going to be shiny and taut. So think taut is tight. So it's going to be, really a lot of signs of the tissue's not getting good perfusion. It's not going to be very healthy, moist skin. It's going to be very shiny, and it's going to have kind of like a tight appearance, almost like a, what do you call it? Like the skin's been pulled really tight. I can't think of any other way to say it. I'm gonna stop repeating myself. And then also I want to look for hair loss, because if I am not getting blood flow, I'm not growing hair. The other thing you might want to check is blood pressure. And it's not that someone with PAD is necessarily going to have a change in their blood pressure, but we want to look for contributing factors. Now, if I have someone who has a flow issue, I want to see what I can do to make it any better in any way. So like if I have someone who has a flow issue and they have high blood pressure, if I can modify that, that can help with that flow issue. So I'm more looking at it to assess for comorbidities or other problems versus like that they're going to have a high or a low blood pressure. So let's do an application check. So a nurse is assessing a client with peripheral artery disease to the left lower extremity. Which assessment finding would the nurse would warrant immediate action by the nurse? So which of the, like, in other words, I'm looking at like which of these, if I don't report, the patient could die or have serious injury the quickest, or which of these is concerning? Because sometimes questions like this are testing my knowledge of if I know what's normal. You're going to see sometimes in a nursing school question where you might think, hey, all of these are going to be things I need to report. But sometimes it's really trying to get you to identify that you recognize, hey, this patient can look kind of sick, but they're okay. This is expected for them. So let's look. So client reports numbness and tingling in their left foot. Well, their left lower extremity has PAD. So I would expect them to have, a decreased flow, therefore having this paresthesia. That's an expected sign. Clients' feet turn pale when the nurse elevates their legs. Well, that's that like elevation pallor, or also just known as pallor. And so that would make sense, because if they have PAD and then I lift their legs up, there's more gravity for their body to have to overcome. So they're going to have decreased flow. And then there's client has an ulcer around their toes with some black tissue. So this is pretty concerning because, even though I know that people with PAD can get ulcers, I see black tissue, and I don't know if this is new or what's going on with it, but this sounds like some dead tissue issue. That sounds kind of serious. This one's the top of my list so far. Client has a 1+ dorsalis pedis and posterior tibial pulse. And so, for that, like I mentioned, that's normal, that's expected. So A, B, and D are all things that can happen. They're going to have signs of decreased flow. They should have not that they should, but they can have signs of decreased flow, but they should not have signs of zero flow. That's where we really want to start intervening. And so for C, that's a sign of like zero flow. If they're getting an ulcer and there's black tissue, there is dead tissue. I need to start intervening. So C is going to be the best answer here. So let's talk about other diagnostics and things we can do for PAD. We want to look for flow issues. So like I said, that you can they can order a arterial Doppler where they can actually see, and you can see like in this picture where they have plaques and stuff like here, but there's decreased flow. And they can visualize. They can even see where does flow terminate. They can also do what's called angiography, and that's like where we go in like the cath lab, where they go in and they pretty much use a guide wire to look at, how open or closed arteries are. So they do the same thing with coronary artery disease. Except now we're doing it in the legs. We're not checking the coronary arteries, we're the blood flow issues in the legs. So we're going in, they can look for blockages. They can also perform interventions if needed. So it's also a procedure that can be done for treatment. Then MRI helps us look deeper in the blood vessels and tissue, so we can do that as well. There's also a couple other diagnostic tests that you might see in future questions or things like that. So it's good to become familiar with these. I'm not going to go horribly in depth with these because they're not necessarily the first or always the test that we're going to do, but it's good to be familiar with them. So the first one's what's called segmental blood pressures, and the other one's the ABI, or ankle brachial index. I'm going to talk about those two on my next slide, but effectively it's looking for differences in flow by checking blood pressures at different places. And then we also want to look at, just like we looked at blood pressure as a contributing factor to PAD, we also want to look at what else can contribute to blockages. So something else that can contribute to blockages is going to be the cholesterol. So I'm going to check that now. Checking the cholesterol, I'm going to expect it to be, elevated, but we want to check on it to see what else can we modify to make these blockages better. And it's not that the statin's going to save the day, but it's definitely going to help decrease things, improve things long term. And one thing I want you to keep in mind, there's a lot of labs and diagnostics for cardiac. You really want to understand with this what you would expect for a patient with the numbers. Like we give a lot of data on our exams where you have to interpret the data. Okay, this is high, this is low. And you can know that, but if you have to know what that means for this patient, like, okay, this is high. Okay, is that expected for this patient or not? Do I need to take action? If it's low, then what am I going to do? So you really want to process that information. All right, so the segmental blood pressures, what you want to think about here is effectively this is a procedure where we're going to take a blood pressure in the thigh, in the calf, and in the ankle. And for someone with PAD, effectively what's happening or going to happen for this patient is that you're going to notice a drop in pressure from when it's up in their thigh to their ankle. So that blank should be as if it's greater than 30 millimeters of a difference from their thigh to their ankle. It's diagnostics of PAD. So you have to think of it this way. Up in my thigh, usually these problems, go as the arteries go down. So if I take a blood pressure in my thigh, it's going to be higher because I have better flow. But as I go down, I go to the calf and then to the ankle, there's going to be less and less flow. So there's going to be a decreased blood pressure. Now you may be a little confused by this because you're like, wait, I thought that they have hypertension with this. They can, but you have to, blood pressure measures flow. So as we're going down, and by the time we get to the ankle, they're going to have less flow there because of the plaque, and the narrowing is going to lead, to them to have such like a significant difference in flow. So effectively, their blood pressure in their thigh is going to be a lot higher than it's going to be in their ankle. That's because there's more flow in their thigh, but as we get down, we have more plaques, more narrowing, so less pressure. Another test that can be done is the ankle brachial index, or the ABI, which is where we take their ankle diastolic blood pressure and we divide it by their brachial systolic blood pressure. And there's a whole chart in our textbook that kind of talks about this and has the numbers. You do not need to memorize these. I do not have them memorized by heart. Do not waste your time with that. But just like, you don't need to know the normals or anything like that. But just know that this is another test that can be done to tell us about the flow for PAD that we can use to diagnose. And then just also know that for some patients, especially those with diabetes, other vessel issues, it may not be as accurate. So just keep it in mind. It can't maybe necessarily be used alone. So how do we know that it's getting better or worse? Signs that they're getting better are going to be that their peripheral neurovascular assessment's getting better. So that would be, you think of all your P's. So better color, better temperature, maybe more sensation or pain. And when I say more sensation, I don't mean that they're hurting, but I mean is that they maybe have better sensation, or they're able to feel things, that they have less of the numbness and tingling, or no numbness and tingling, that they're going to be able to move everything okay, have better pulses. I could go on, but yeah, you get the point. They might also say that, hey, I'm able to walk around more. I'm able to get around better. It doesn't hurt as bad. My intermittent claudication is improving. And then signs that they're getting worse, we're going to worry about like them having necrosis. Necrosis, I mean, they can be cyanotic, they can be black, like the patient that I talked about that I had, they had some of their toes were blue and some were black. And so it kind of just depends, on the patient, how severe their PAD is. There also can be signs of infection, so we want to look about and generally with PAD, because there is less blood flow, there's not as much of this, but there can be drainage or pus or redness, swelling, things like that. We also would look for all the things I said for improvements in the peripheral neurovascular, for signs are getting better, the opposite. So decreased pulse, worsened temperature, worsened paresthesias, worsened pain, or again, maybe worsened lack of pain, because again, with a patient with PAD, sometimes it's actually worse if they're not feeling something. Things like that, but going into all that, or inability to move it, these are all going to be decline. And then the end complication, of course, I'm always worried about is there's such bad ischemia that they need amputation. So like for my patient, they were planning on taking her entire left arm, and as well as her, the rest of her fingers and toes, most likely. So what can we do medically to treat this? So medically, we want to do things that are going to, we need to think about all the contributing things. So first I have a plaque problem, or I have all this plaque buildup. So things like cholesterol medications can be super helpful in order to decrease or increase my flow and decrease a lot of the problems that I'm having. If my cholesterol's down, managing those plaques can be useful. We're also going to give medications, and I'm going to talk about them next, what are known as antiplatelets. These are, I always think about, they stop things from clogging so much. I'll talk more about them in the next slide. There's also medications like pentoxiflin or cilostazol, which are peripheral vasodilators. So you have to think about, this is just like angina, but in the legs. And so what do we do for angina that's in the heart? We give nitroglycerin, which is a vasodilator. So the same thing is here for this pain. So you may think, oh, intermittent claudication, it's pain, I'm going to give pain medicine. But remember, their pain is not from muscle aches or something like that. Their pain is because they're not getting oxygen. So what do we need? We need a vasodilator. We need something to open up that artery to allow for better flow. And these are just like, the other medications where they can take them before they're up and moving around, etc. It can be useful for their exercise or activity tolerance. And then there's also surgeries that can help to restore perfusion. So there's going to be things like the most common one you might see is what's called a fem pop or femoral popliteal bypass. And so this is like literally, it's just like a cabbage or a coronary artery bypass graft, where effectively what they're doing is there's a blockage, like you can see it here in this picture. There's this blockage. All the yellow is plaque and blockage. And so what they do is they're like, hey, there's nothing really flowing through that. So they take a vein and they start it from above the blockage, and then they literally are bypassing that blockage. So they're creating a vein, and it's going to grow into being an artery. It builds up the strength of an artery with time. And by doing that, they are allowing for what do you call it, a better flow. And so they don't do anything else. They don't take out the other arteries, but they just pretty much build them a new blood supply. So think of this like if you had a route that you took to work that always had traffic. What do? You find a new route, and that's effectively what they're doing here. Is they're finding a new route for blood flow, like creating like collateral circulation. There's also what's known as an endarterectomy, which is where they can go in and scrape plaques in the arteries. And then, like I talked about with angiography, where they can go in and place stents and open things up. So now let's talk about antiplatelets. On the next slide, I'm not going to show you the video, but there's a really great Nurse Mike video that talks about the difference between antiplatelets and anticoagulants, but students get this really commonly confused. So to kind of keep it simple, antiplatelets are in the body. They are a part of the clotting process, but they are not a part of the coagulation cascade when it comes to like the circular chain that it takes to actually form a clot. Now they can get together and form like little tiny microclots. But the bigger issue that comes with platelets is that platelets like to hang together and get stuck together. And then they're going floating around. And when they see plaques hanging or a plaque rupture or like any sort of, break in the blood vessels, they attach to it and they can form these clogs in your arteries. Or if you already have plaques and then the plaques start to, rupture, etc., they're like, oh, it's a plaque party. And so they want to get together. And so I think of platelets, they form a plate over a clot or form a plate over plaques. And effectively, they lead to clogging. So I think of antiplatelets as anti-clogging. And this is the baby of all of the types of medications that can help to make you less likely to get a blood clot or less likely to clog your arteries. This is the baby of them. So this is usually the one, these are usually the ones we use for prevention or people that have, we do use them also for people that have had some cardiac events. But if you see someone on antiplatelet, think this patient is at risk for a cardiac event. When I say cardiac event, I'm talking about like MI, stroke, etc. Or if they've had a stent placed in the past, it just helps for the stent to not collapse or for there not to get another clog there in their artery. So the biggest side effect, I want to make myself a note. The biggest side effect we're going to see with antiplatelets, or as when we talk about DVTs later, anticoagulants too, but all of these anti-meds is going to be bleeding, because all of these, they're going to stop your platelets from hanging out together, but your platelets, when they hang out together, they also help to help you to clot when you need to. Like, if I cut my arm, my platelets, they create that beautiful plate of cells that helps to, pretty much create, a window or a barrier to the rest of the world to protect me. They help me to start to, protect my body from any sort of intruders. So they are amazing at creating plates. But, when I have someone who's really high risk and I don't want those plates being formed, I don't want those platelets hanging out together. So this pretty much stops the platelets from sticking together, stops the platelets from hanging out together. So they're less likely to clog in my arteries. The big ones that you're going to see are aspirin and then also clopidogrel, which is also known as Plavix. We'll talk about each one. And pretty much, I know these medications worked if they have no cardiac events, so like no MI, no heart attack, stroke. Okay, I said the same thing twice. MI, I say PE, stroke, things like that. And I shouldn't see any evidence of clots if this is doing its job. It's not perfect. Again, it's the baby one, but it's something. So before we get into learning about these, let's do a teaching question. So a nurse is discharging a client with peripheral artery disease on aspirin 81 milligrams daily. Which statement by the client indicates that teaching was effective? So anytime you have a teaching effectiveness question, you always want to look at, am I looking for what's right or am I looking for what's wrong? So this one is saying that this patient is on 81 milligrams of aspirin and I'm looking for what is right. So 3 of these are going to be wrong. 1 of these is going to be right. So the first one says this medication will decrease my risk for having limb ischemia and blockages in my arteries. Okay, I like that. That sounds pretty accurate. But let's keep going and see the other ones. This medication will help me to make less platelets, which decreases my risk for blood clots. So sometimes, like in a question like this or in some answer choices, you're going to see some answers that are partially right, but not fully right. So you always have to make sure the whole answer is correct. You have to own that whole, the whole answer choice. You know, sometimes students will like really like a part of an answer. And so they're like, I know part of it wasn't right, but the other part was so right. So I had to choose it. Then there is this sorry, let me back up here. So I don't think aspirin makes less platelets. It just stops them from sticking together. So I don't think this is right. That part of it. So then it says this medication will decrease the amount of plaques accumulating in my arteries. Now I know antiplatelets do something with plaques, but I don't think they decrease the amount of plaques. I think that's talking about cholesterol meds. So that one I think is wrong. And it says the medication will decrease my intermittent claudication pain when walking. So there are meds that can help with intermittent claudication, but this isn't one of them. So another way to like kind of play around with this question or to study is you could look at this question and be like, that's wrong for this, but what med would have to be in this question for this to be right? So if this said as a nurse is discharging a client with peripheral artery disease on statins, then the right answer would be C. Or if this said a nurse is discharging a client with peripheral artery disease on pentoxifylline or cilostazol, those vasodilators we talked about for intermittent claudication, then this would also, D would be right, but it has to be the right medication. And that's the thing is that when you're reading a question like this, a lot of times the other answer choices are going to be correct for something else you need to know. So that's why sometimes students, like when they have a lot of information, but it's not organized in their head, they get mixed up and they're like, ooh, I know I do want less plaques. I know there's intermittent claudication. That's a hallmark symptom, but they sometimes can get mixed up and, pick the wrong answer. So always make sure you're looking at that patient with that med. How is that, and we'll talk about this when we get to like heart failure and stuff like that. But this patient, this med, what's the best, what's the best option? So the only one that's applicable for this patient with this disease and this med is going to be A. And I didn't really get to show you, but yeah, I'm not going to show it to you, but that's the Nurse Mike video. It's anticoagulants versus antiplatelets. Great stuff. So yeah, you could just kind of watch a little bit at the beginning. So let's talk about aspirin. So with aspirin, this is probably one of the most common antiplatelets you're going to be seeing given, and you're going to see it given more commonly because it has, it's cheaper and more affordable, and it's well tested and it's been used for a long periods of time. So aspirin is considered an NSAID. So you do want to consider if the patient is allergic to aspirin. They're also, or if they're allergic to aspirin, they're probably allergic to other NSAIDs, or if they're allergic to NSAIDs, they'd probably be allergic to aspirin. And I have mnemonics through a lot of these. You're welcome to read them if they're helpful to you. So there's also different dosages that a patient can receive. Now, we don't dose these medications, but as the nurse, the dose is really going to tell you a lot about the patient. If I have a patient that's on 81 milligrams, that is a prophylactic dose. In other words, you could also see it as what's called a cardiac prophylaxis, or they are on a dose that's going to help them to prevent attacks and stuff. They just need low dose. It's what's called low dose aspirin. So the 81 milligrams, you're going to see a lot of patients on this. So if I see this on a patient, I'm going to think they've had cardiac heart problems, or they're really at risk for them, or they have a stent or something like that from the past. If they're on 325, I'm going to think they've recently had a procedure or event. That's a higher dose. So we're usually kind of almost treating something or really strongly trying to prevent something. So usually there's something new or different that's happened. So that tells you a lot. But the one thing I want to kind of, hit home about aspirin is a lot of times if I ask my students in clinical, like, hey, what are you giving aspirin for? They'll say pain. And we really don't give aspirin for pain, especially if it's a daily dose. You always want to think about like, okay, why would I give 81 milligrams daily for this? So you can look at the dose and stuff. Now, it's occasional we might use aspirin for pain, but I'll tell you generally in the hospital for pain, we do acetaminophen or Tylenol, or we'll do ibuprofen if they can't get Tylenol. Or stronger meds and stuff like that too. But aspirin, especially if we're talking about 81 milligrams, that's not even a good dose for someone who is having pain. If they were gonna, like if I was going to treat pain, it would be that higher dose. But just keep in mind, these doses are usually trying to prevent and help with problems that someone's having when it relates to their cardiovascular disease. So they either are at risk for a problem or they already have a problem, or if it's the higher dose, they've had a recent procedure, other stuff going on. So like I mentioned, the big thing we worry about with both of these meds are going to be this one, and then clopidogrel is going to be bleeding. Now, usually for aspirin specifically, we worry about GI bleeding. It causes a lot of GI upset. It's really hard on the stomach. So like we talk later in the semester about like gastritis and other things. And usually they have to be off aspirin and NSAIDs for like a period of time, or if they have peptic ulcer disease, stuff like that, because it really rips at the stomach lining. That's why they've created enteric-coated aspirin, and that's also why they recommend you take it with food. Full glass of water and stuff like that can decrease a lot of that GI upset. I might mess up another slide. You also, if you're another thing that is specific to aspirin is going to be ototoxicity. In other words, it can cause ringing in the ears or hearing loss. So you definitely want to consider this if you are, with your patient, especially if they're on high doses. It usually takes pretty high doses to lead to hearing loss, but something to consider. If you're having a procedure, they need to make sure, if they are having a procedure, you want to make sure and check with the doctor. Like, for example, if I have a patient who's on aspirin and they're going to go to surgery the next day or soon, I would ask if I want to give the aspirin or not, etc. So sometimes they'll stop it for a day or a couple of days, because if they're about to cut into a patient, they obviously do not want to have that patient being at higher risk for bleeding. Let's see if there's anything else I want to add. I think that's the most stuff. Like, you're mostly worried about the GI stuff. High doses, we're worried about hearing issues, and then let your doctor know if you're going to have any procedures that you're on that med. Clopidogrel is a lot easier to talk about, because with clopidogrel, it has a lot less side effects. And so there's, they're in risk for bleeding in general, but the GI issues are not a thing. And they don't have the hearing issues either. And mostly we're just looking for bleeding. And we want to think where we see bleeding. So usually like on, for patients that are on antiplatelets, like where we're going to see bleeding is stuff like from brushing their teeth. They may have bleeding gums. They can also have nosebleeds more easily. It is possible if it gets more serious, they might have blood in their urine, blood in their stool, stuff like that. So we're looking in all those places, and there's more. We'll talk more about bleeding stuff later, but we want to think about all the common places. And, if a patient does start bleeding, it's not that, it's not usually profuse bleeding, but they're just going to be more likely to ooze, from their IV sites and other stuff too. So just kind of keeping an eye on that. I'm going to teach them bleeding precautions, just like for aspirin. And we'll talk about bleeding precautions in a later PowerPoint that talks about the anticoagulation. I want this patient to avoid trauma or injury, because if they fall, they're going to take longer to clot off, and they're going to be at higher risk for complications from bleeding. I thought I heard something, sorry. Same thing, if we're going to have a procedure, we need to tell our doctor that we're on clopidogrel to see if they want us to stop it. And then on the flip side, we also don't want to stop this suddenly. So, it can have a really bad rebound effect, and a patient could end up forming a blood clot or having really serious clotting issues. So we should never stop it without the direction of a doctor. So if someone, we're getting into the nursing stuff. So let's talk about, let's say someone has a fem pop or femoral popliteal bypass, excuse me, they're going to have an incision. If you look at this, they have an incision usually from their thigh all the way down to their ankle. It's a very long incision. So I really need to think of me as the nurse, what are my priorities or what am I going to be focused on for this patient? So, I'm going to be focused on those 7 P's and 1 C. I'm going to be doing really frequent assessments, circulation, circulation, circulation. It's going to be my focus. Any minor changes can mean a major problem. Then I'm also going to do, very aggressive pain management because obviously this incision can be very painful. Surgery can be painful. So I want to make sure I'm staying ahead of their pain because I really want to get them up and get them moving. And if they're hurting so bad, they're not going to be able to move. I'm going to monitor for bleeding, any signs that they are forming a blood clot because with that new blood vessel, they can form a blood clot. A little bit more easily, especially after surgery, or any sort of perfusion issues. I'm going to watch their incision site for infection because if it's not, they can bleed, they can be more likely to bleed or form clots, but also it's a really long very long incision. So because it's a very long incision, it also can more easily get infected. And you have to think of where it is, like the groin is a dirty place. So we definitely want to be watching it closely. When they're in recovery, we really don't want them to be flexing their knees for too long or in the same position, like prolonged sitting or independent position that can get really bad edema and stuff like that. So we want them moving. We want, to decrease edema that can help with their pain, help with their mobility. So we're going to maybe put compression stockings on, or, if they start to get edema, we can elevate. We just really want to get them moving. It's going to help to build up that blood vessel from a vein to an artery and get them preventing complications, especially post-op. So one thing I want to note is before I was talking to you about arterial problems, in general, arterial problems, like when the legs are dangling, the legs are dangling. When there's poor flow to the legs, I want them dangling. I like their legs down. That's for PAD in general, but just know specifically after this procedure, and usually I also don't want compression. Like if I'm already having trouble getting flow down here, if I put compression on this, it's going to make it even worse or even harder to get flow to my feet. So normally I don't want compression. I don't want elevation. That's usually what I want for venous. We'll talk about it. But in this case, the compression is necessary to help to get them more mobile, decrease edema. And now we have these new blood vessels. So they have this new circulation. So normally PAD, it's a no-no to compression stockings and elevation, but just after this procedure it can be okay just to help with flow, because if I get too much edema I can have even worsened or decreased flow. So this is the only time compression and elevation is okay for PAD. So general, as the nurse, what I really want to focus on is remembering that pain is because it's a lack of oxygen. So I shouldn't be going out of my way trying to get some, strange pain medicine orders. Like their pain is ischemia pain. So I need to make sure I'm treating their pain accordingly. Encouraging the energy conservation. So rest periods between activity and walking is probably one of the best exercises someone with PAD can do. And then the lifestyle modifications are key, like they need to quit smoking. This is probably one of the most crucial things that they can do. The textbook talks about it, like out of all of the lifestyle modifications you can make, smoking may have the greatest effect compared to any other intervention. So because of how much damage it does, especially to the peripheral arteries. Managing other things, blood glucose, blood pressure, keeping them all stable. Doing other things like losing weight. If there's less pressure on the legs, it definitely can allow for better flow. Low sodium diet, which can help with the other things like hypertension as well. And then managing cholesterol, we need to manage those plaques. And we want to do, of course, there are medications to help, but diet and exercise help with that as well. And then I want to teach them, how to, check their capillary refill, pulses, temperature. And when I say temperature, I'm talking about temperature of their feet. So in other words, I want them to learn how to take care of their own perfusion. I want them to avoid injury because remember, if they're getting less flow to their feet, they're much more likely to have a serious injury. And they could end up, again, if there's no flow, then it can't heal. So they're going to have healing problems. And we teach them foot care just like diabetic foot care. And I think I have another slide where I talk about this coming up, so I'm not going to go into it right here. And this has been a longer video than I was expecting, but yeah, as a whole, we want to do foot care as well for these patients so that we can get them feeling and doing better, and preventing injury. Because remember, diabetic foot care, everything comes down to is that these people, and like for diabetes, they can't feel it because of diabetic neuropathy, but PAD, they can't feel it because of the poor flow. And so they're really high risk for injury, infection, and tissue death. So we want to take care of it. So as a whole, I am managing risk factors, getting this patient up and moving, trying to encourage them to do activities as tolerated, and do all we can to improve the flow, treating the hypertension, treating the things that are, I want to say pissing off, but bothering the blood vessels, like having high blood glucose, managing their cholesterol is so key too. So those are like kind of the trifecta: managing your diabetes, managing your blood pressure, and managing your cholesterol. Yeah, and then just frequent assessments, regular checks for making sure they're getting good flow. All right, I think I've talked myself enough in a circle. I hope this was helpful. I'll see you hopefully for the next one's going to be shorter. See you there.